Everyone, it's right at 2 o'clock, so we'll go ahead and get started with today's webinar. My name is Larissa DeLuna with the American Heart Association, and welcome to the Southwest Affiliates webinar focused on stroke in children and young adults. Started today, I'd like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. If you have a question or a comment, feel free to unmute your line with *6. You can also type in questions in the question and answer section of the WebEx meeting window. All handouts will be sent to attendees within 1 week of today's webinar. Also feel free to visit heart.org/SWA-quality to view a recording of today's webinar. So go ahead and get started today. I'm going to introduce our speakers for today, Dr. Timothy Bernard and Dr. Sharon Poisson. Timothy Bernard is an associate professor at the University of Colorado. He is a pediatric neurologist and clinician scientist. 10 years ago, he founded the first stroke clinic in Colorado and currently serves as the director of pediatric stroke program at the Children's Hospital Colorado. He also serves in several educational capacities, including the director of the Pediatric Neurology Residency Program and co-director of the AHA Bucher Pediatric Stroke Research Fellowship, training the next generation of scientists dedicated to understanding and treating children with stroke. Dr. Bernard seeks to understand the mechanisms underlying childhood stroke through his NIH and AHA-funded research, exploring endothelial dysfunction and coagulation abnormalities in children with stroke. Our second speaker is Dr. Sharon Poisson. Dr. Poisson is an assistant professor at the University of Colorado, a vascular neurologist and neurohospitalist. Poisson serves as the director of the Vascular Neurology Fellowship Program and the co-director of the AHA Bucher Stroke Research Fellowship Program. Dr. Poisson's research focuses on etiology, prevention, and treatment of transient ischemic attack and stroke. She previously conducted research evaluating gender role in the treatment of carotid stenosis in TIA, as well as the role of intracranial large vessel stenosis in TIA. She has specific interest in the increased trend of ischemic stroke in young adults, and she is currently studying the role of atherosclerosis risk factors and race as the potential cause of this trend. And turn it over to Dr. Bernard to get us started for today.
Hello, can everybody hear me okay? Okay, fantastic. Thanks for joining us today. We're going to spend the first half an hour talking about children who have stroke, and then I'm going to hand it over to Dr. Poisson, who's going to talk about young adults with stroke. We're going to be talking about unique features and new advances in the field of childhood stroke. My funding is through the American Heart Association. I have no conflicts of interest. Two main goals today. One is to understand the unique features of childhood stroke presentation, and the other is to review recent advances in understanding of childhood stroke and the pathway for recovery in children. We talked a little bit about how time is a brain, and lessons learned from our adult colleagues about how to organize stroke centers, as well as the importance of treating the whole child. The first thing I wanted to do is give you a little bit background about childhood stroke. Childhood stroke is really a number of different diseases. When you think about pediatric stroke, you think about kids who have clots in their veins or pediatric venous stroke, a bleed or pediatric hemorrhagic stroke, or a clot in their artery that goes up into the head, plugs, and ischemia or lack of blood flow and oxygen to tissue. The type of stroke we'll be talking about today is arterial ischemic stroke. Really different kinds of arterial ischemic stroke in children. Childhood arterial ischemic stroke happens between 1 month and 18 years of life, and the other is perinatal arterial ischemic stroke. We'll be mostly about children who have stroke today. Interestingly, perinatal arterial ischemic stroke is fairly common in children, occurring in 1 in 4,000 live births, and is probably the most common cause of unilateral cerebral palsy. Stroke are very challenging to treat and diagnose because it's a fairly rare condition. To make the diagnosis, you have to have a child who has acute onset neurologic deficits, and then has imaging that corresponds and conforms to the arterial distribution associated with that deficit, confirming stroke. About 1 to 2 children per 100,000 per year will have an arterial ischemic stroke. In Colorado, we see 20 to 30 cases in our hospital every year. reasons we don't completely understand, boys have stroke more often than girls. Average age is about 6. Majority of the time, we don't completely understand why kids have stroke. About 2/3 of the time, we don't have a complete understanding of the etiology behind why a child has a stroke. About 2% of the time, they'll have a heart disease. A clot will form in the heart and go up into their head. 7% of the time, they'll have a dissection or a tear in one of the arteries in their neck or head, where a clot will form and go up into their brain, causing a stroke. And about 5% of the time, kids will have sickle cell disease, which is a risk factor for stroke in children. Kids with stroke will have some sort of injury that's lifelong. 2/3 to 3/4 will have a neurologic deficit for life, and 10% will actually pass away from their stroke. So it's a disease. So a little bit about recent advances in how we treat stroke, specifically talking first about the importance of treating stroke quickly, and how we can learn a lot from our adult colleagues on how to do this. So, children present with strokes just like adults do. About 80% of the time, they'll have one positive symptom is fast. Now, fast is a way you can remember what are the symptoms of stroke. Drooping, arm weakness, speech difficulties. If you see those things in a child or adult, you should think stroke. Time is important. You should call 911. And when people have looked at children who have stroke, they present with these symptoms a great majority of the time. 2/3 of them will have some sort of face, arm, or leg weakness. About half of them will have speech disturbance. Interestingly, many of them will have a headache, which is a little different than adult stroke. Then will also have difficulty with dysarthric or speech. It's interesting and very different between childhood stroke and adult stroke is a child who presents with a focal neurologic deficit probably have a stroke, needs to be on a differential. 80-year-old male walks into the emergency department not moving his right arm, he's probably had a stroke. If a 3-year-old, maybe not so much. We need to think about many other things that can cause that type of deficit in a child. Common being a seizure with a post-ictal or post-seizure TODS paralysis, some sort of infection or encephalitis. We'll see a complicated migraine. And sometimes, with kids with a focal neurologic deficit, we'll actually have them see a stroke. Many pediatricians will think about this rightly first before this, but it's important that stroke is prevention. Unfortunately, in the United States, and the mean time to diagnosis of stroke is about 24 hours. And stroke is suspected on the initial presentation about half the time. And when we're giving talks like this, and one of the reasons that many people in my field are trying to do a lot of education, is that as pediatric neurologists, as adult neurologists, as EMS providers, as nurses, we all need to do better in recognizing stroke in kids so we can get that number down. Interestingly, when you do have a stroke or suspected stroke on an inpatient service, you get called for a consult. My friend Becky Eichord has demonstrated that many of the time you are going to have some sort of stroke syndrome once you're in the hospital. What's really interesting is if you do get called for a consult, a lot of the times the markers of the stroke aren't that benign. Demonstrated that for half the time you have something bad going on that's not a stroke, like a tumor or ADM or an empyema or an AVM. So many times, even when you have a mimicker of stroke in children, it's very serious, not benign disease. I'll give you guys a couple of cases here. These are cases that have been adapted from real cases, but they're not exactly like the cases I saw. So when I was first a resident and getting interested in stroke, I saw a case very much like this. A 7-year-old boy was taken to a rural emergency department after awaking from a 3-hour nap with right-sided moderate weakness, arm greater than the leg, and difficulty talking or aphasia. He had headache and photophobia. They did see head there, which is negative. Didn't do any imaging of the vasculature or the vessels in his head, and didn't do an MRI. An important point here is that to acutely diagnose a stroke, you do need an MRI most of the time. Headed to this outside hospital for observation for presumed complicated migraine. Now, while this could have been a complicated migraine, as I mentioned before, stroke shut on the differential. No, this is the possibility of stroke or TPA with the family. No one considers strokes mimickers such as ADM, encephalitis or seizure, and no further evaluation is undertaken. The next morning, he wakes up. His has progressed to being completely hemiplegic or difficulty moving his arm at all on that right side, and he's transferred to Children's Hospital, Colorado, where he's diagnosed with a left MCA stroke. The first time I saw this guy, the mom said to me, "Is there anything else that could have been done?" One of the things that I would say is that I think there's a lot that can be done for a child like this. Shown that in adult stroke centers, by adopting quick management strategies, we improve outcomes. Now, many people think a lot about TPA as a way of improving outcomes in adults with stroke, and certainly it's proven that not only intravenous but endovascular techniques for hyperacute therapy can improve adult stroke outcomes. But there are other really important things that you can do to improve outcomes that include fluid management, glucose management, surveillance of recurrence, and really understanding the situation you're in. In addition, by understanding the situation, you're able to improve parent communication, decrease anxiety and frustration about delays in diagnosis, and offer an upfront conversation. That when I'm talking to a child or to a family of a child who has a stroke-like syndrome, means I'm talking about why I'm not doing something and why I am doing something. I'm saying things like, I'm not recommending TPA because, or although the head CT is negative, stroke could also be a possibility. By getting families through your thought process at the time of diagnosis, you really allay their fears and anxieties. A lot of the families that I've seen over the years who have delayed to diagnosis, although the overall outcome I believe would have been the same, their anxiety around waiting for a diagnosis is really challenging. So at Children's Hospital, Colorado, there's a stroke team available 24/7. These people have expertise and interest in childhood stroke. We have dedicated stroke alert procedure, MRI available 24/7, and stroke alert order sets in the ED and the ICU in order to identify stroke quickly and have experts available quickly who can identify and treat stroke. Here's the second case. Happened 10 years later. Again, slightly modified. This is a 10-year-old girl who's taken to a rural emergency department after awakening from a 5-hour nap with side moderate hemiparesis or weakness, arm rather than leg, and mild aphasia, very similar to the first case. She's taken to an outside ED where they suspect stroke and transferred to Children's Hospital, Colorado. Interestingly, in the two cases that I put together to create this mock case, the ED provider there actually listened to one of the talks just like this and knew about childhood stroke and suspected it quickly. At Hospital, Colorado, MRI, confirmed stroke and until M1 narrowing at 8 hours. She's aspirin started on IV fluids. Mom says that she may worsen overnight due to M1 narrowing. The family is also educated about the reasons she is not a candidate for TPA. This is an MRA of the vessels in her neck and head. And what you see is here is as the ICA comes up from her neck up into her head, then the MCA on the left side. Right here, this filling defect or black spot is a clot sitting there. And we knew when we saw this clot that she had some sort of stroke in her MCA territory and was probably at risk for further events. And the next day, her weakness compresses to complete hemiplegia just after standing up to go to the bathroom. Understood was that this was likely a flow-mediated event where when she stood up, she wasn't getting enough blood to get past this clot. And so smart resident did was lay her down to improve her symptoms. When she was laid down, when she did lie down, her symptoms got completely better because the blood flow then flowed into her head past the clot. The family is very appreciative of our care and attention, and even got a waxing and waning coverage, waxing and waning symptoms of the next 24 hours. Our outcome was improved by understanding the situation and partnering with the family around treatment. So when you start thinking about acute care for children with stroke, one of the things that always comes up is the trial, or the thrombolysis and pediatric stroke trial. The trial that we were a site for, run by Kate LaFawn and Gabrielle DeVeber, and it was designed in 2010 to be a 5-year multi-center international safety and dosing trial looking at safety and dosing of TA in children. And unfortunately, when we started this trial, I don't think we were quite ready as a group to enroll. We didn't have our stroke centers completely ready. And about 2 years into this trial, the trial unfortunately closed. But there's a bit that I think we learned from this trial, and one is I think that really we improved our preparedness as a group of centers across the United States to treat stroke. In the beginning of the trial, there were 17 participating centers asked, how prepared are you to take care for a child with stroke? On a scale from 1 to 10, being not ready at all, and 10 being completely ready, the center reported a 6.2 readiness. Think about this for a second. These are 17 centers across the country that signed up for this, that are interested in this, and they only felt like their readiness was a 6.2. That's a surprising low to me. This arrow here shows when the TIPS trial presented on this graph, and this graph demonstrates differences of readiness to treat kids with stroke. Things from having a pediatric neurologist on site, having MRI stroke available, having a stroke team, having updated MRI stroke availability 24/7, having either stroke ED or ICU order set. And what happened after the initiation of this trial was that, these centers and becoming much more prepared by the end of the trial. And as a result of that, ended up having a much better feeling about how they're prepared to take care of kids with stroke acutely, going from a Likert scale of 6 to almost a 9. So in summary, children with stroke have similar symptoms to adults. Think fast when you're thinking about trying to understand symptoms of stroke: face, arm, speech, and time. For children with childhood stroke are very similar to those with adults, and by treating kids quickly, we're likely to have improved outcomes. Stroke alert systems will be site-specific and likely vary by sizes and resources, and systems increase preparedness for childhood stroke. Okay, I'd like to talk a little bit about the importance of treating the whole child, which is something over the last 5 years or so I've spent a lot of time thinking about, and one of the things I think we're becoming much more prepared to think about in our stroke community. I did a small study here with my friend Casey Clevenger, where we went to our stroke support group and asked the adults and kids there to tell us a little bit about what they thought was important about their recovery from stroke. And what they said to us was that the recovery was really a very anxious time, where they had fear, anxiety, frustration, with being worried about recovery, or the fact that they may not regain function, a lot of about recurrence or concerns about having another stroke, a lot of energy spent on trying to garner the appropriate resources and coordinate them with making decisions. And a really important one for our teenage population in particular is feeling a sense of normalcy, returning back to normal after their stroke. And in response to this, at Children's Hospital Colorado, we really try to have a multidisciplinary approach to children with stroke. One of the important backbones of our program is having a stroke support group. And stroke support group participants reported that there was significant amount of support and of normalcy by attending the support group. And one of the things that we've also learned is that it's important to target adolescent group, particularly as a vulnerable group. And they might need their own group in particular, and do things where they go outside of the normal setting by either using social media or doing cool things like rock climbing. And we take a multidisciplinary approach in our clinic, where we have multiple specialties who are able to mobilize not only medically, but to address the psychosocial aspects of the child's presentation. So in all of our clinics, we have access to neurology, hematology, rehabilitation, surgery, rheumatology, pharmacy, as well as a social worker, access to have an opportunity to join in research, and also to join our stroke support group. So in our support group locally, our mission is to provide support, education, and advocacy for families impacted by the range of outcomes of all types of pediatric stroke. This is run very depthly by Amanda Kenny. We're affiliated with the International Alliance for Pediatric Stroke. We do have some funding locally, although it doesn't take a whole lot of funding to run something like this. Some funding through our hospital, and we got some startup funding from the Professional Miracles Foundation. I said one of the things that's really important to understand is that as physicians, we're often focusing on the mental illness, and the broader child and family is something that we need to focus on as well in order to give the best care possible. What I wanted to do in the first 25 minutes of our discussion today was to give you a background about childhood stroke, tell you a little bit about the unique features of childhood stroke presentation, and then tell a little bit about some of the recent advances in childhood stroke, specifically highlighting the importance of diagnosing stroke quickly, the capacity for stroke centers in the pediatric realm to develop systems to identify, diagnose, and treat kids with stroke, and then talk briefly about the importance of treating the whole child. So on through that, I'm going to go ahead and hand over the microphone to Dr. Poisson, and then we'll be happy to take your questions afterwards.
Hey, Tim. I'm going to go ahead and just jump right into talking about young adult stroke. I have a lot of stuff to cover here. So I have an interest in young adult stroke, and I'm doing some research in combination with the UCSF and Kaiser Northern California group looking at young adult stroke. And when I came here to Colorado, I actually had the chance to start working with Tim, who has a really well-developed pediatric stroke center. So we've developed a young adult stroke clinic that kind of mirrors a lot of what they've already done in the pediatric stroke group. So this is my funding through NINDS, no conflicts of interest. I'm going to touch a little bit on the epidemiology of young adult stroke, why young adult stroke is important for us to be learning about now, a couple of the specific risk factors and causes, and then a little bit of guideline on how to do diagnostic workup on a young adult stroke and how that may differ from adult strokes, as well as data that we have about treatment and secondary prevention, and then talking about kind of what the needs are in this area to start thinking about for the future. Everybody asks me, what is a young adult? And so this is my calculation is that it's my age plus 10 years, less than that. So that way I can always stay young. But to be honest, the definition of young adult varies from study to study and generally is based on kind of convenience. So the lower limit, when you look at studies of young adult stroke, is anywhere between ages 15 and 20. The upper limit varies anywhere from 40 to 50. So kind of where childhood ends and young adulthood begins and where young adulthood ends and older adulthood begins is not totally clear. I'm going to focus on ischemic stroke. Obviously, hemorrhagic stroke is another big part of young adult stroke. And the incidence of ischemic stroke compared with other types of stroke, or the proportion of ischemic stroke, is somewhere between 20 and 80% of all strokes in young adults. I usually think of it as about 50% of all strokes are ischemic and 50% are hemorrhagic, but it's not totally clear what that number is. But compared to in older adults or in stroke overall, about 85% of overall stroke is ischemic. So usually when people think about ischemic stroke, we think about older people, and clearly incidence of stroke in older people is higher than in young people. So incidence anywhere from 88 to 149 per 100,000 people, and it really just depends on the race and ethnicity. Young adults, it's somewhere between 3 and 11 per 100,000, which is a little bit higher than, as Dr. Bernard talked about, somewhere between 1 and 2 or 1 and 3 per 100,000 in children. So, the most important things I think about young adult stroke is that the trends in young adult stroke aren't really following the trends that we're seeing in stroke overall. So we've gotten pretty good at treating and preventing stroke overall. So you can see that over this 20-year period that the rate of hospitalizations for stroke in people ages 65 and over have been decreasing over time. You can really tell what's going on down here for the under 65-year group, but I'm going to show you. So this is based on another study that looked just at strokes, different types in young adults. And so in this study, we used ages 15 to 44. And you can see that over this time period, they show that amongst all of these groups, hospitalizations are actually increasing, and most dramatically among men 85 to 44. So this is the opposite trend that we've been seeing in stroke overall. This is a study we did based on death certificate data, and over the course of about 20 years, what we saw is that in the green bar is young adults, 20 to 44. The gray bar is older adults, so over 45 in this case. So over this 20-year period for intracerebral hemorrhage and subarachnoid hemorrhage, you can see that there was a pretty significant decline in death from ICH and SAH, both in young adults and in older adults, pretty similarly between the two. See the opposite trend in deaths among young adults from ischemic stroke. So there was actually an increase in deaths attributed to ischemic strokes among young adults. This wasn't a significant increase, but was clearly different than the trend that we're seeing in older adults. And then if you look at a racial breakdown, this is from Kaiser Northern California data. Over this year period, you can see, especially among African Americans, we're seeing a big increase in trend of stroke hospitalizations. So I think what we're trying to make the case for is that there's a gap in what we're doing between stroke prevention and treatment amongst over adults compared with just the young adult group. In the past, it's been thought of that young adults are so rarely affected by stroke that spend a lot of time thinking about how to prevent it isn't worth our time. It turns out, actually, because it's increasing, I think that it's a fairly important area to think about. And in addition to that, the impact of stroke on young adults is pretty high, both on individuals, on families, as well as on society. So a young adult who has an ischemic stroke often is going to live with a disability and the repercussions from that stroke for many decades. And the lifetime cost of stroke, given that there have many decades of disability and potential years of productive life lost, the cost of stroke on society is high. So the lifetime cost of stroke in a young adult has been estimated about $500,000. And I think another area that's unique about young adult stroke compared to stroke overall is just that there are different problems that our patients are dealing with, similar to what Tim was talking about with pediatric stroke. So these are often people who have young families, who have children. They may be the breadwinner for their family, and so a loss of income can happen from this. And it often can change the way a young person sort of views themselves and understands themselves as a healthy person. So one of my big questions when I started thinking about young adult stroke is just, who are young adults? Are they kind of just like kids with stroke but dressed up as older people, or are they actually just like older adults with stroke, similar risk factors to them? So in this group, in the young adult group, men and women have pretty similar rates of stroke, but if you break it down by age, in the under age 35 group, women are more likely to have stroke, and men are more likely to have stroke ages 35 and over. Similar to the overall stroke population, African Americans have a twofold higher risk of stroke compared to other races. I'll go through each of these, but you can see in the table, this is this doesn't include everything, obviously, but some of the common risk factors for childhood stroke are on your left, and for overall adult stroke are on your right. And the question is kind of where do young adults fit in this continuum? Do they have their own unique risk factors? Do they fit more in with childhood stroke or more with adult? And I think it's probably a combination of all of those things. We have great data on the etiology of stroke in young adults, but there are some larger studies that are good, and the Helsinki Young Stroke Registry is probably the largest study out there, including over 1,000 patients ages 15 to 49. And when they looked at 1,000 patients with young adult stroke, they found that actually 60%, which is a pretty huge number, had dyslipidemia, and almost 40% had hypertension. Obviously, atherosclerotic risk factors are fairly common in patients with ischemic stroke, even in young adults. The most common causes that they found in this study were cardioembolism, about 20%, dissection, which definitely has a higher proportion in young adult stroke compared to stroke overall. About a third of these strokes were cryptogenic, no clear cause. There are several other smaller series that mirror this for the most part, that also find high incidence of typical atherosclerotic risk factors, and also finding cardioembolism and dissection as two of the largest causes. You can see over here in the graph, the red bar is strokes of undetermined cause. So the younger the age, it seems like the more of the strokes that we don't have a determined cause. The dark blue, this is other determined cause. So these are things like dissection, and you can see sort of that remains fairly stable throughout young adulthood, but starts to get a little bit less common as people get older. Cardioembolism is in green, and it's really not until about age 35 where you really start to see typical small vessel disease and larger atherosclerosis start to creep in. Again, a not complete list, but as comprehensive as I felt like we could look on the screen at, of different types of etiologies for ischemic stroke in young adults. I'm not going to talk about all of these. We obviously don't have time for that, but I was going to focus on just a couple of them. Atherosclerotic risk factors, we've talked a little bit about. There definitely is evidence that atherosclerosis can develop early in life and is related to the number of typical risk factors. So there are both carotid ultrasound studies as well as autopsy studies from young people who pass away from trauma and other unrelated causes that have found that there are the beginnings of atherosclerosis even in as young as childhood. There are some studies that suggest that some of these risk factors may be increasing over time in children and young adults. There was a study that looked at a large database study that looked at the incidence of stroke hospitalizations over the course of a couple of decades, and amongst those patients who were hospitalized for stroke, the prevalence of hypertension, diabetes, obesity, and hyperlipidemia increased over that study period. Dissection is just another one to mention because it is one of the more common causes of stroke in young adults. I'm not going to talk too much about this, but just to explain a little bit about what it is for anybody who doesn't know, is there are several layers to the wall of the blood vessels. There are 3 layers in the extracranial blood vessels. A dissection occurs when there's a tear in one of those layers of the wall. Because of that tear, you start to kind of form this pocket where blood stagnates and anytime blood sits still, it tends to form clots. A piece of that clot can break off and go downstream and cause a stroke. The other mechanism for stroke in dissection is if this clot gets big enough, it can actually occlude the vessel. The most common places that we see dissections are in the extracranial or cervical carotids and vertebral arteries, much less common in the intracranial blood vessels. On your right here is just an MRA that's looking at a dissection. You can see this sort of little pseudoaneurysm actually in the cervical carotid artery. About half of dissections are related to a known trauma. The other half we consider spontaneous, where there's no clear trauma causing them. Again, briefly to mention PFOs, as I think the question about PFOs comes up pretty often in this age group. So that about a quarter of the entire population has a patent foramen ovale, and so it's just thought to be a variant of normal. But if you look only at patients with cryptogenic strokes, the strokes where we really don't have a good explanation despite a good workup, having a PFO, there's about a 2 times odds of having a PFO if you've had a cryptogenic stroke compared to if you have not. And if you look only at young adults with cryptogenic stroke, there's a 5-fold odds. Clearly an association, but it really isn't clear that the risk of recurrent stroke is higher in those patients who have a PFO. There's been a lot of research that's gone into trying to figure out what to do with PFOs, and for many years we really haven't had the data that we need to recommend PFO closure routinely. Actually, just last month, an FDA panel reviewed some data from the RESPECT trial and has recommended for approval of one device for PFO closure. I'll just show you a little bit about that study. This is the RESPECT study. It was run by John Carroll, who's one of our cardiologists here. What they did is they took young people with cryptogenic strokes and who had PFOs and randomized them either to PFO closure versus medical therapy. And this is the initial results of that study before they did more long-term results. And there was a difference in outcomes, but it was not a significant difference at that point. They now followed this group out longer, so now we have 10-year results. And you can see, so this is the group with closure, and this is the group that didn't get closed. And when they looked at stroke overall, they found there was not a significant difference in the group that got closed and the medical therapy group. But look only at prevention of cryptogenic strokes, meaning it's not related to their atherosclerotic carotids, it's not related to their atrial fibrillation. There was a significant difference between these two groups. So at this point, I think the jury's still out a little bit about PFO closure, but I suspect that if the FDA approves this device, there may be some changes in guidelines coming up about how best to identify patients who may benefit from PFO closure. Again, very briefly to mention substance abuse, this is something else that comes up often in the young adult population. Substance abuse certainly isn't unique only to young adults, but it's something that is a bigger risk factor in young adults compared to older adults because there are so many fewer other risk factors that they have. So we do that tobacco use increases the odds of stroke by about 4-fold. Heavy alcohol use has been associated with stroke. Cocaine had a pretty significant effect on stroke risk, 13-fold odds. Amphetamines actually cause more hemorrhage than ischemic stroke, but there is some increased risk. And I think the jury is definitely still out on marijuana. There are just case reports associating marijuana with ischemic stroke. This is a study done in the Cincinnati Northern Kentucky group. ago at this point, but showing that these are among young adults who've had strokes in the 90s, sort of early 90s compared to late 90s and to 2005. And you can see that the number of patients with stroke who were using illicit drugs increased over that time period. So becoming a larger risk factor over time. So what should we be doing when we see a young adult with stroke in the hospital, I think is a good question. And how should we be treating them differently than the way we treat overall adults? There's really no great evidence-based algorithms for how to evaluate young adult stroke. It's pretty poorly understood what are the highest yield tests and how many things do we need to be doing differently from older adults. There are a lot of different possible etiologies for stroke in young adults, but they're all uncommon, so how routinely should we be looking for them? So I like to think about it as using a really tiered approach. This is from a study, this is, I think, kind of interesting, showing young adults what tests they actually had done. In light gray, this bar shows what percentage of young adults with stroke had that test done, and in the black bar, it shows how many of those test results were helpful. And so you can see in this study, hypercoag workup was done on almost 90% of patients, but was only helpful in 15%. The tox screen was similar in that it had relatively low yield. It looks like when they chose to do LPs, they were helpful, and I suspect that's because they're only choosing to do them in patients who they have a pretty high suspicion of something like vasculitis. Echocardiography was pretty helpful, and that may be because it's finding POs or congenital heart disease that was unknown previously, but Holter monitoring almost helped nobody, so AFib is pretty uncommon in this group. And CT or MRI and angiography were fairly high yield tests. So this is really based on, my own experience and my own sort of suggestions about how to go about treating or diagnosing patients with stroke in the young adult group. I think starting out with the typical adult evaluation makes a lot of sense. These are really well-studied, well-known risk factors, and common things are common. So head CT and MRI, non-invasive vascular imaging, basically in everybody, evaluating vascular risk factors. This is sort of the low-hanging fruit. We know what to do with these things. Monitoring, at least in the hospital, makes sense, although longer-term monitoring in young adults is probably much lower yield than it is in older adults. So really being picky about who you use longer-term monitoring in. And an echocardiogram should be done in everybody. Things to consider: tox screens, inflammatory labs, pregnancy tests, and when. And then really based on history only and on high suspicions, considering things like conventional angiogram, CSF evaluation, rheumatologic labs, hypercoagulable labs, genetic testing, infectious studies, and then potentially looking for clots in the legs or pelvis if there's a PFO present. Treat patients with stroke in the young adult time period. We certainly have some data on this, though the data is not as good as it is in older adults, because young adults are really underrepresented in these large clinical trials. It does appear that IVTPA is safe and effective in young adults. Actually, young adults probably have a lower risk of symptomatic ICH secondary to TPA, and functional independence is higher in young adults who get TPA compared to older adults. There's really single-center studies looking at endovascular intervention specifically in young adults, although I think expert opinion would be that endovascular treatment should be helpful in this group. Other considerations in acute treatment of young adults is that young patients with large strokes, so especially those who have large MCA strokes, malignant MCA strokes, malignant edema after stroke is much more common in this group than in the older adults. And so early consideration for decompression is really important to improve mortality and potentially improve functional outcomes. Variable data about what we should be doing for secondary prevention in young adults, again, because they're underrepresented in these large trials. We do know if they have modifiable risk factors for stroke on the atherosclerotic risk factor sort of spectrum, we should be treating those and doing them aggressively. It's well accepted as standard of care to use antiplatelet medications in young adults with stroke. Stats are a little less clear. We know that in stroke overall, high-dose statin treatment lowers the risk of recurrent stroke, cardiovascular events, or vascular death, especially in patients with known atherosclerotic stroke. This was a non-randomized study that came out of the Helsinki study, looking at young adults with stroke of undetermined etiology. So these are young adults that did not have a clear atherosclerotic risk. And they actually found that, so you can see over here, these are young adults with stroke who never got started on a statin. These are young adults with stroke who got started on statin at some point in the follow-up period. And these are young adults who had a continuous statin. And the numbers here, I think there were only maybe 30 patients in the non-continuous statin and continuous statin groups, and a much higher number in the never statin group. But it looked like there was at least a trend towards decreased risk of recurrence or other vascular events in patients who were treated with statin. Still unclear who should be put on a statin and for how long. So adults have a 7-fold higher mortality over 10 years if they've had a stroke. Their annual risk of recurrent stroke is between 1% and 3%, with a cumulative lifetime risk of about 20%. Functional outcomes, so the way we look at functional outcomes most of the time is using modified Rankin scores. And I think many of you probably know that modified Rankin scores are pretty limited in what they're actually looking at. So they're very good looking at things like being able to do your ADLs and to walk, but beyond that, they're not very sensitive. So if we use a modified Rankin score, 78 to 94% of young adults with stroke end up independent, but only about 50% can return to work. 30 to 50% end up with long-term depression or fatigue. And it's pretty hard to really quantify all of the impacts on functional outcomes of families, but I do think sort of the inability to return to work in about half of young adults with stroke speaks a lot to the amount of recovery that they're having and the amount of disability they're living with. Again, this is just looking a little bit at mortality in young adults with stroke. So this is ages 18 to 50 with the first ever stroke. And you can see that at 5 years, there was a 5.8% mortality rate, and by 20 years, there was a 26.8% mortality rate. And if we're thinking about, young adults in their 20s, a 20-year mortality rate of 26.8% is very high. Causes of death, about 15% ended up dying of ischemic stroke, but I think pretty impressively, 29% with cardiac causes, and that suggests that young adults with stroke also have a lot of risk for cardiac disease, commonly with infections and malignancy. So moving on from what we do with strokes right now, I think the next question is, what can we be doing to do a better job of preventing, recognizing, and treating strokes in young adults? So I think the first step is things like this, so just educating people that young adults can have stroke. If you talk to a non-stroke population of physicians, many of them will sort of look at you oddly when you talk about young adult stroke because they don't think it exists. And I think that's true even in ED, is that a lot of ED physicians have never seen young adult stroke because it's relatively rare. So a young person comes in with aphasia, they often don't think stroke first and think other things like intoxication, and so young adult stroke can get missed. Poor education about risk and signs of stroke leads to delayed diagnosis and delayed treatment, and we all know that delayed treatment leads to worse functional outcomes. Young people really need to be screened for stroke risk factors like high blood pressure, diabetes, and high cholesterol. I think this is a group that often isn't going to see their primary care doctors frequently or doesn't have a primary care doctor. Even when they do see primary care doctors, how often they're being screened for these things or treated when they're found to have a little high blood pressure is not, we don't do as good a job as we should. The other thing is building better support systems for young adults with stroke and their families. Something that our pediatric stroke program has done a great job of is making sure that children with stroke have great resources for helping them with schools. They get EPs, they have social workers who are really adept at helping hook them into networks of support. And I think we don't do as good of a job of that with young adults who have stroke. So they often feel like they don't fit in with the typical stroke population, but there aren't a lot of resources out there for them. More research on young adult stroke. We need to understand better what are the causes of stroke in young people, how often are atherosclerotic risk factors part of that. Are there other genetic or acquired abnormalities in blood vessels that we should be screening people for, or at least having high on our list of concerns when somebody comes in with stroke? What role does hypercoagulability play in stroke in young people? Is there a higher risk young adult population that should be screened more aggressively to try to prevent stroke? And then how should we be treating patients with young adult stroke? I think we just don't really have all of the data that we need to guide us. My take-home points are just that strokes can happen in young adults. It's becoming more common over time. The causes of stroke in young adults overlaps both with childhood stroke etiologies as well as with older adult stroke etiologies, so we need to be thinking broadly. Stroke in young adults has a large impact both on individuals and families as well as on society as a whole, and we need more research and education in order to better prevent and treat young adult stroke. I think that's all I have. So this is our HA Viewer research team here that is studying stroke in young people. And then Tim and you already, the pediatric acute stroke team down here. And several of us, myself, Jennifer Simpson, William Jones, are actually part of the adult stroke team also. Take questions now.
Thank y'all both so much. If anyone has any questions, you can feel free to press *6 to unmute your line. *6. Yeah, go ahead.
My name is Heather Roberts, and I'm speaking from as a parent with a child that had a stroke in utero. She's 4 years old now. I just want to say thank you for putting this out there and showing that we as parents are not crazy. Things are going on, things are happening with our children that have had strokes, and I really, really appreciate that. So I just want to send that message. I don't have any questions, but I wanted to give that message out there. I appreciate it.
Thank you for the feedback. Any other questions or comments? *6. Hi, Cap. The last lady that spoke, I'm in with her. Thank you for doing this. My son actually recently had a stroke in April, and he's 4 years old. And at this time, it's idiopathic. It was really challenging to live with. And this last week, took him to the ER, and I'm kind of at a loss as to who do I go to when I have concerns, because I feel like everybody kind of looks at me funny, like, don't worry about it, like you don't know whether you should talk to, like, your pediatrician doesn't really, is the pediatrician. They kind of deal with things like on an everyday basis. Then you have the hematologist, but they're the blood person. Then you got the neurologist. Kind of like, okay, the onset of his stroke showed, there was behavior change, like in retrospect. I'm like, oh, okay, he was acting funny that day. His lip is doing something, and I kind of like this past week I went to the ER because his lip was kind of drooping, and the feeling of like just people, like, calm down, he's fine, doesn't help, and then you're just kind of at a loss as to who do I go to say, okay, is this normal? Is this normal? Is idiopathic? Is this normal?
So I fully understand that stroke in kids and families with that is a very emotional and challenging time. It's really important to find providers that you can partner with. One resource for you, the International Pediatric Stroke Study. That's a group of investigators that are dedicated to treating children with stroke. And if you look at their website, you can find, for people who are interested in learning more and have such resources in childhood stroke, it might be one idea for you to try to figure out who in your community would be the right person to connect with. But I think your question underlines, highlights how challenging it can be for families to deal with this uncertain situation, and I think it's part of the overall care we provide is trying to help you navigate that.
Thank you. Star 6 to unmute your line. The other question I had is, so in terms of idiopathic is really hard to kind of live with. He's only 4. So where I hate to say this, but like straight out, where is the best place in the States or in the world that actually does the research or that's willing to keep pushing for an answer with me? I understand. I'm constantly told, you may never get an answer. I get that. But I feel as scientists, you don't come up with answers to you don't come up with vaccines and questions overnight. Sometimes, it is an ongoing study. And the frustration is getting people who keep spitting back in your face like you may not get an answer, and prepare yourself for that. And I understand that, but I keep fighting for an answer, and it may not be they may not be in the timely manner that I would like one. But what resources, hospitals? I know there's Colorado. I'm in Virginia. The top in Boston, and then I've heard stuff about Canada. So, where are the best places to go to be in line with people that will fight to help you get those answers?
The 4 places mentioned are all places that have, such as myself, dedicated to seeing and understanding children with stroke. I think that if you align yourself with somebody who is part of the International Pediatric Stroke Study, that's a good starting point.
Okay.
And if you look at those 4 centers that you mentioned, are all very involved with that group.
Okay.
And I think that's a good resource to try to start to understand where the places are that are really trying to be involved with research, because every one of the centers involved with that are involved with research.
Okay.
The other point that I will make, that I make to a lot of my families, a lot of times we don't totally understand why kids have stroke, and that even people who do this every day, all day, most of the time will not have an underlying etiology. The line to that, if there is one, is that the kids who have a known reason for their stroke are oftentimes much more likely to have another event than kids who have a completely negative workup. So if you have a completely normal workup without any vascular abnormalities or any cardiac abnormalities or any problems with your blood or what we call thrombophilias, if those things are normal, your odds of having a stroke-like event are much lower than if we do find abnormalities. It doesn't make you feel better as far as you won't have an answer, but if you're in that group of having a very complete workup and there's absolutely no clue, that group's less likely to have another event by quite a bit.
But then it's like, why have one in the first place?
Yep, I agree with that. I'm frustrated with you about that as well. I see kids every week where I don't know they had a stroke, and that's why we partner with other people to try to study this. I totally agree with you about that. And I hear frustration.
Thank you. Your personal story, we appreciate that.
Sure.
Does anyone else have anything with questions or comments? Star 6 to unmute the line.
Hi, this is Dr. Ziff at Mountain Medical Center. We have a very large adolescent population, and we see a fair number of people that have complex migraines. How much of a workup do you do to make sure that they're not having a stroke, especially considering imaging, CT angiogram, MRIs?
I think over the last 10 years, we've become much more aggressive with treating kids with complicated migraines because you can fake it out. It's really hard to know when a kid presents with complicated migraine-like symptoms, which ones are going to be complicated migraines and which ones are going to be strokes. I get a couple kids that had moya that had diagnosed with, they were complicated migraines for months. I can think of another kid who was diagnosed with brachial plexus injury and ended up having a history of a stroke. So I think that as long as you have it on your list of things you're considering, that's the first step, is making sure that you think to yourself, could this be a stroke? What I often have done over the past 5 years that I think is a nice strategy is it's one of the situations where you're not totally sure and you get a CT and the kid's in the middle of nowhere and can't get an MRI right away. It's a reasonable thing to put them on an antiplatelet for a couple days before you can get imaging and see them. That's a strategy sometimes I've used. It is a difficult situation because then end up not being stroke, but a small number will. Did that answer your question?
Oh. Yeah.
Instructions? 6 to unmute the line. Any more in the webinar queue? Those came off of mute and asked, so we'll go on to questions. Any other questions on the phone line? Star 6. There's no other questions. I just want to remind everyone that the slides and then a recording from today's webinar will be sent to you within 1 week. Dr. Bernard and Dr. Poisson, thank you so much for taking the time to take on our webinar today. We really appreciate it.
Be here. Thank you very much.
Sure. Well, thank you, everyone. Have a great weekend. We appreciate you attending.